to a very specific request of the CND. We've had 2 resolutions in 2 years in the 58 and 59 session of the Commission before this. 2 resolutions saying that the international community dealing with the world drug problem have to establish a continuous dialogue with the scientific community. This was institutionalized, although we are speaking about an informal scientific network. In reality, there was an institutional request of member states in the Commission, approved unanimously twice, to establish a dialogue with the scientific community. It means that the policymakers, the international policymakers dealing with the world drug problem, feel the necessity to have a relationship with people working in science, and they don't want to ignore any more science behind addiction medicine, behind drug policy in general. Let me say that also it is only 1 day after the CND started, the 60th session of the CND, but we started really in a very exciting way with the historical visit of Dr. Margaret Chan to the CND. It was the first time that the Director General of WHO was attending the Commission, attending the opening, and calling my director brother Yuri. So it was a great demonstration of the link between drugs and health and drugs as an interagency cooperation. It was also great to start yesterday in the opening with the short speech of Nora, Dr. Nora Wolkow, who is giving us the honor to be with us, and the short statement of the youth initiative of the Youth Forum. Today, now I give the floor immediately to the 2 co-chairs, Dr. Wolkow and Dr. Toufiq, but I want to explain also the presence here with us of His Excellency Ambassador Shamaa from Egypt. Ambassador Shamaa has had a very impressive role in the last years as the man who conducted the entire Commission to prepare the document, the outcome document, to approve it unanimously in the Commission and then unanimously in New York during the General Assembly. He has done a really great job, but I consider him, for this reason we invited him, also a co-founder of this scientific network, because he was encouraging us in moving in this direction, and he encouraged the member states to be on the side of science instead of the side of ideology. With this, I give the floor to Nora.
Good morning, everybody, and thanks very much for having me present. And before I start, I want to thank the Informal Scientific Network, who actually was very thoughtful in coming up with recommendations, and my co-chair, Dr. Jallal, Toufiq, as well as the staff that have so ably enabled this to happen. So I was teasing Gilberto, and I said, since we're an informal scientific network, is this going to be an informal statement? And what it does is actually bring forward what we as scientists actually recommend on the basis of how to properly and optimally address substance use disorders. And so I'm going to be reading. This is a document, again, that was the product of the scientists that were nominated by different countries to come up with an integrated statement that is valid not for just one country, but across the globe. The scientific community welcomes the recognition of substance use disorders, including dependence, as a chronic, complex, relapsing, multifactorial health disorder with biopsychosocial causes that can be prevented and treated, as stated in the UNGA's outcome document. This provides a historic opportunity to change the perspective about people affected by substance use disorders by filling the existing gap through a new approach in which these disorders are treated like any other chronic medical disease. In addition, the treatment of substance use disorders reduces transmissions of infectious diseases, decreases crimes, improves professional productivity, and family relationships. In order to achieve the goals outlined in the UNGA's outcome document, the scientific community advises member states to build drug policies around the recognition that substance use disorders reflect complex biopsychosocial factors and vulnerabilities, and that it addresses stigma and discrimination. This can be achieved through a public health approach that on the one hand includes effective and efficient strategy for preventing, identifying, and treating substance use disorders, and on the other, excludes criminal sanctions or punitive interventions, which have been proven to be ineffective in addressing substance use disorders. It is also recognized that a reduction in severity of substance use and associated behaviors is beneficial. The public health approach prioritizes measures aimed at improving the health of individuals, families, and communities through promotion of healthy lifestyles, interventions to combat disease, prevent injury, and detect and control infectious diseases. In this context, research has shown that substance use disorders are preventable, provided that interventions utilize evidence-based methods adapted to the cultural, economic, and social conditions of each country. Scientific evidence strongly shows that substance use disorders are also treatable and should be addressed as other chronic medical diseases. The treatment of substance use should be voluntary and integrated within the general health care and the behavioral health care sectors, as outlined in the UNODC WHO International Standards for the Treatment of Drug Use Disorders. Moreover, treatment needs to be evidence-based, non-stigmatizing, available, accessible, affordable, as well as cultural, age, and gender relevant. In addition, individuals with substance use disorders in the criminal justice system should be provided with treatment options, which will also reduce reincarceration and crime. In order to assess progress in regard to the implementation of the provisions outlined in the ONGAS outcome document, it is crucial to use specific, standardized, and simple measures to evaluate the impact of prevention and treatment interventions, not only to demonstrate their usefulness, but also to assess the unique needs and health trends in each country. There is also a need to systematically collect data on the determinants of health and to identify disparities in risks, harms, and access to services. The scientific community urges member states to establish reliable information and data collection systems that allow the identification of outcomes such as reduction of symptoms, improvement of physical, psychological, and social functioning, and decreased risk for negative health consequences such as HIV, hepatitis B, hepatitis C, tuberculosis, and mental illnesses. Information collected and analyzed should be used to inform evidence-based decision-making and to evaluate drug policies. The policy-making process should also engage diverse stakeholders in order to address the complexity of the problem from various perspectives, such as public health, education, law enforcement, criminal justice, scientific, healthcare, and social work systems, and include best practice examples from countries with diverse cultures, needs, and resources. Member states should also ensure access to controlled substances for legitimate medical and scientific purposes, including the recognition that some of the scheduled substances may be therapeutic. A provision should be made to facilitate research with them. The scientific community should be supported worldwide in order to produce much needed research and knowledge on issues related to the impact of substances on the brain and behavior, especially new synthetic drugs, on the impact of drug policies on substance use trends, including the dynamic interplay between supply and demand, the impact of different drug policies and the effectiveness of prevention and treatment strategies when tailored to the unique cultural context of member states.
Thank you, Nora. Thank you for this statement, very rich proposal from the scientific network. Now I give the floor to my colleague of WHO, Dr. Vladimir Poznyak.
Thank you very much, Gilberto. This is a pleasure to be at this event when the deliberations of the scientific network is being presented, because this advice from the scientific community is essential for implementation of the operational recommendations of the UNGAS on the World Drug Problem 2016. Also, this advice from the scientific community is essential not only for the UN organizations, for UNODC or WHO, it's essential for the countries which which made a commitment, their governments made a commitment to achieve to go on the way of implementation of operational recommendations of UNGAS. In this context, I would also like to mention the Sustainable Development Goals, which define the agenda for member states, for civil society, for academia, for UN system up to 2030. And in these Sustainable Development Goals, in the health targets, there is one which you know very well, with 3.5 to strengthen prevention and treatment of substance abuse. And definitely this task should be based, implementation activities should be strongly based on the best available scientific evidence, on the best practices which can be collected, disseminated and analyzed from different jurisdictions, from different countries, and made available to all those who are in the beginning or in the process of improving or developing their services and their treatment policies. And finally, I just want to emphasize that this scientific network is another example of excellent collaboration between UNODC and WHO, and also the collaboration with the prominent scientific community, with prominent scientists around the world. And on behalf of the World Health Organization, I would like specifically to thank Dr. Wolkow for her leadership in moving this scientific network to the results as presented today. Thank you very much, and we look forward to work with the member states and with the scientific community on following up on the recommendations and implementation of commitments and recommendations which were made at the highest possible level in the UN system and in the broader international community. Thank you.
Thank you, Vladimir. Now I give the floor to our special guest, His Excellency Ambassador Shamaa.
Thank you very much, Dr. Gerra. Just strike out the word special. We are, as Dr. Nora mentioned, in an informal setting with informal recommendations, and that's the way I like it. First of all, I would like to thank you very much for inviting me to be with you here, and that brings me back like 3 years when we had our first meeting, when I had the honor of starting preparations for the UNGAS. Now, I've prepared, a statement, but I'm not going to do that statement. I just want to leave you with a few ideas or a few pointers. First of all, what we have achieved through the UNGAS outcome document, especially in the areas of prevention, treatment, and rehabilitation, would not have been possible without your inputs and your contributions. And I'm not saying that, out of being nice. No, that's a matter of fact. Your input and your contribution and your advice to member states is paramount, especially when we talk, for instance, about prevention or treatment and rehabilitation. It's a sine qua non to be able to achieve any useful result. Now, these inputs also, and the fact that they have been reflected in the document, in the UNGAS document, and the extensive parts that we have on public health, on treatment, on rehabilitation and prevention is a witness to that, and witness to the importance actually of scientific research to ensure the sustainability, effectiveness and quality of any work that is undertaken by member states, by governments, by local authorities, in the areas of prevention of drug use and treatment. Now, having said that, and having listened very carefully to the recommendations that you worked on this survey, which, I cannot but subscribe to. They are also a reflection, or they go in line with the OBS outcome document. But let me try to challenge you, if I may. And that's following our discussion that we started to have before the beginning of the session. Now, several questions I think we need to think about. Okay, now you've made that contribution to the UNODC process, we have the document. A question that needs to be asked is, how can the CND and UNODC further help in that? We are now in the post-UNODC phase. We are in the implementation phase. So any of the nice things that we have, whether in your recommendations or in the UNODC document, if they are not implemented, then best of luck to all of us. And that's all of us, with no exceptions. So that's the number one thing we need to consider. How can CND and UNODC really work at that? I'm not forgetting WHO, by the way. Don't worry. I can never do that. So the thing is, we talk about policies, which is fine. I think there is a growing, a solid recognition of the importance of sound policies. You wouldn't find much disagreement with that. But what I'm still not seeing very much is, okay, where is the end product? And what I mean by the end product here is the end product that Dr. Toufiq will be working with. In other words, where are the protocols? Where are the treatment and rehabilitation protocols to be applied? Prevention. Yesterday I was discussing with the youth about communication and awareness raising campaigns. Well, let's face it. We do our campaigns, we direct them towards the youth, but they don't listen to us. They have their other sphere through which they communicate with each other. They don't communicate with you on your same platforms. Forget about TV and newspapers. We're even talking online platforms. We have our platforms, they have different platforms. They don't like to mix and match with us on this. So that is a very important element when it comes to prevention, for instance. How can you get your message through to them? You're not imposing it, but you're simply sending that message for them to process. That's first point. Now, protocols. When we talk about protocols, and this is one of the things you've mentioned in your recommendations, but that's also in the UNODC document. The issue of cost is very important. You can have the best high-tech, top-notch, state-of-the-art protocol that you can apply on 10 individuals with a cost of $1 million in country A. But when it comes to country B, there is no way on earth that you'll be able to do this. First of all, nobody's going to provide you the money from the public health budget, which is already being severely, strained and overstretched. So what is it that we're talking about? We need to have a final product that is implementable, modules, protocols for treatment and for rehabilitation. How can we do that? Well, we have UNODC to serve as a platform, depository of such protocols. Now, one very interesting remark I've heard, or description I've heard yesterday of CND, that the CND is sort of turning into the Davos of drugs. So be it. That's good. That's nice. I mean, this is something that is useful, that all stakeholders, all interested, come together to discuss and see how we can do our jobs and what we believe in better. So the part of the final product, the protocols, is extremely important. Second thing, that they are, I don't want to use cost effective, but that they are affordable. Why also do I talk about affordable? Affordable is one part, but also that they are effective. I don't know about you, but some of you must have definitely stumbled upon so-called treatment centers or rehabilitation centers, which, as a matter of fact, you go in, you come out, no change in condition. I don't want to go as far as saying that some might even just be a business for the sake of a business, not for the sake of being a health care or a health provider. Am I right or wrong? That's there. That's out there. Now, I don't care about what they want to do, if it's about earning money or not earning money, but I seriously care about the person who goes in there. Who goes in there comes out sometimes even worse. Now, that contradicts with what you say about the need to fight stigmatization. Well, we will not be able to fight stigmatization like this. Because if a patient or if somebody who has a drug use disorder goes into treatment and comes out same or even worse, what does that do with the rest of society? You actually increase the stigmatization, you don't reduce it. And that relates to a question of that sometimes you have this perception of drug treatment as being ineffective. Is it ineffective? Is it effective? Do we know if it is effective? So, this is a question we need to answer. But how do we answer it? We answer it not just simply by saying, no, it is effective. Yes, show me protocols that can be applied that I can measure. The measurement and assessment of the results of treatment protocols is important. I also don't want to waste time and money and resources that are not there into protocols that do not necessarily work. So, you mentioned a beautiful word in our discussion. We all need to be humble. I fully agree with you. We need to be humble because we are supposedly in the service of our societies. And here it's a true example of science in the service of, not member states, it's in the service of human beings, to respect the human rights of every single person. So, the issues of how do we measure the success, how do we measure if protocols are effective or not, and the cost factor of these protocols. I sincerely believe this is the next stage we need to put all our efforts in. And when I say we, I basically say you, because you are the scientists. You are the people who have the knowledge, not officials, not states parties. It is simply you who have this knowledge. But this knowledge needs to be, pardon this phrase, maybe it's not the proper one, but it needs to be packed into the final product. The final product that your colleague in country Z will take and implement if it needs a bit of tweaking to fit into his circumstances, the local aspect, fine be it, but then it's a product that he can implement and hopefully will have results with. If we manage to do that, we will be able to satisfy and complete all the recommendations that we have in this. Sorry for taking a long time. Thank you very much, and thank you for all your efforts.
informal, but I really believe in this informal issue because I think that ideas cannot be contained in formal containers. No, ideas are spreading such as the viruses, and there are no borders for ideas, and the informal setting for ideas is the best to disseminate new things. On the side of creating protocols with the WHO, and before in 2013 we created the International Standard of Prevention. With WHO we have created the International Standard of Treatment that are now under this stage of field testing to obtain at the end of the story protocols. And when it is very impressive for me that an ambassador is speaking about protocols, because in our world, sometimes the colleagues working in addiction medicine don't have the perception that the protocol will be necessary. I always make a terrible example. If I'm affected by a lymphoma, that is a very treatable disease now. If you catch the lymphoma in the first stage on the one side or the other of the diaphragm without symptoms, you are able to have 97% of curable, of cured situation and complete recovery. And who is going, in your opinion, to have treatment for a lymphoma by an hematologist who has not read the last updated protocol in terms of radiotherapy and chemotherapy to obtain this result? This should be this strategy, this modality should be applied also for our disease. But this is very far from what is the reality. In our disease, everyone seems to be to have the best ideas, and the best things, not to be shared self-referential, not to be shared with other colleagues, and not to be published in a peer-reviewed journal. Let me underline also a very important thing that Ambassador Shamaa said, that is the issue of who is making money on the skin of the people affected. For sure the narco-traffickers, for sure the big pharma, the big alcohol, the big tobacco, but in reality also some providers, they are providing low quality intervention or no quality intervention, are simply making money on the patient, and the result is aggravating the condition of our patient, aggravating the stigma. So Ambassador, thank you for underlining this in a very dramatic way. So with this, we give the floor now to our audience. I'm very happy that M3 is almost full, and so take away the scientists sitting here in the first lines. We have a good audience, and I'm very happy that the scientific hearing is attracting people to discuss. You can manage to if you want.
Yeah, sure. Well, first of all, I would like to maybe just say 2 words. First of all, thank you so much for granting me the honor to co-chair the work of the Informal Scientific network this year. And it's very easy to co-chair when you have people of great value like Nora and Elizabeth. I mean, just listen to them. They do the job, they co-chair. The second thing is, you're talking about humbling. I think it's working in this field is very humbling, and we're even more humbled when we know that you come up with recommendations, and then you end up see them in the world. What happens is, I don't think that policymakers are those perverted, shallow people and willing. I don't think that's the case. The problem is, most of the time, and I've been around long enough in developing countries to know that sometimes they just don't know what's happening in their countries. They don't know. They don't know anything about drug use. And when you talk to them and you open their eyes to the reality, then they start being interested. But then, even if they start being interested, the main challenge, I think, is, and I'm talking about developing countries, and it could apply also to the developed countries and advanced countries, is most of the time, you have the knowledge in the hands of some academicians, and they are totally dissociated from policymakers, where the resources are. And they could be, even if they're sparse, of course. And then the academics are in their offices, policymakers are in their offices, and on the ground, there are NGOs willing to work, enthusiastic to work, but they have no knowledge and no money. And this triangle, most of the time in developing countries, just don't exist. The triangle of linking policymakers with resources and then expertise in the hands of scientists and academicians, and the enthusiasm and the willingness of working within the community in the hands of NGOs. I think that's the most challenging thing, how to make that triangle work. So thank you very much for giving me the floor. Thank you, Gilberto. And the floor is yours for the questions and answers.
Thank you very much, Mr. Chair. Dr. Ahmed Al-Jamal, Scientific Advisor of Drug Enforcement, Sudan. In fact, I'm very excited to know that there's now a scientific network support of drug control, and that was something that we have been looked for a long time. However, just few questions to Nora to start with. I know that you have called it a scientific community, so how come do you have a specific definition for the scientific community? Who are the participants and how they are, how you can bring them together? What is the guidelines for the participation and so forth and things like that? Maybe it is available some at any website or something like that. But just I want to know how to get into that, to have the keys to that. Something which is very, very important, that the reduction measures and the research and the standards of treatment and the evidence-based approach and so forth. All these are, I think, things that need to be addressed cautiously because of, as you mentioned, the complexity of the situation. Because we are dealing with substances that are controlled and prevented by law in some communities, and at the same time we want them to be available, for example, for medical reasons, for scientific reasons, and to be affordable and to be accessible and so forth. So this also needs education to the scientific community, which you will define. And I don't know what are the mechanisms for the knowledge and the research enhancement in this area. We want to be part of this. For the WHO, I think the standard methods and the identification of the substances are very important. And also we have not only the treatment of addicts, but there are some people who may be affected and need very rapid treatment, for example, in cases of acute intoxication. So the measures and the antidotes and so forth, the availability of this to member states may assist also significantly in fulfillment of that. I know that if I may suggest that maybe it is present, but again, the scientific application for the scientific community may assist in bringing together all the ideas of the different stakeholders in this area. Ambassador Khaled Shamaa, I think that he provided very serious statements and very difficult to prove that the treatment is worthless. I don't know if I understood this as well. But I think that it must be there must be visions and missions for this and this assessment and strengths and weakness and SWOT analysis to the strategic plan of the scientific community to play a very important role in drug control. So we can look at the weakness and the projects that have not fulfilled their objectives, so that we can come, because it is not only treatment, but we have other things associated with drugs in the scientific arena. So just a few ideas and questions that may assist me to come with better performance in the future in drug control. Thank you very much.
Yeah, and I'm going to start by addressing the question But before I do I do want to actually highlight again the enormous amount of effort that Dr. Gilberto Gerra has placed on this issue. And I would say, because I know him now for so many years, it's his passion and his courage that actually has made many of these advances happen in the informal, or whatever way you want to call it, scientific network. But I think that is one of the things that I do want to recognize for everything he has done. We the scientists, and as was mentioned, the challenge is we can come up with theories that are just elegant and beautiful, but cannot be applied to solve the problem. And science, we want to use science for a purpose, to solve the problem of substance use disorders. So in the election, first of all, the members, the scientists that are part of this informal network were nominated by the member states themselves. But they actually include a very diverse group of scientists, not only because their experience of their country has led them a perspective that is different from each one of them, but also their own expertise, from basic science to clinician to epidemiology to services research to implementation. Because the most challenging task that we have is how do we move this forward in a way that is going to be sustainable. And that requires very creative thinking. So one of the first tasks that actually Gilberto gave us, which I think was very, very, very just to the point, was for very specific items and processes that need to move forward so that we can create protocols, so like we call in the United States, standard operating procedures. Let's get metrics. Because without a metric, we actually are unable to understand whether what we're doing has evidence or not. And so yesterday we spent basically most of the day generating simple metrics that are going to be applicable across all of the countries. And that will allow us to actually evaluate that we create those protocols, whether the protocols are working or not. And one of the issues that emerged in our discussions, there were two things that were, in my brain, very, very salient in this discussion of the metrics. Number one, create report cards for treatments and prevention interventions. So you can have more than one treatment intervention, right? But you can have different levels of quality on the basis of where the knowledge is. And use that as a mechanism for those treatment programs or prevention programs to ameliorate themselves, so that there is a way that the system itself can improve. That's one. And the other one is adopting the notion, and you asked me the question, what is it that you want to achieve? Well, we want to achieve to prevent the devastating effects of drugs. That's what we want to achieve. So how do we do that? And in medicine, the way that we do it for infectious diseases is this model that we call it continuity of care, that allows you to identify at the different stages how you are doing. How many people, for example, infectious disease, HIV, how many people have been screened for HIV? Of those that are HIV positive, how many of them have been referred to treatment? Those that have been referred to treatment, how many are there on treatment? Those that are on treatment, how many have viral suppression? And that allows you to see how effective your intervention is. And so we are proposing to use a similar model to quantify how countries are doing with respect to their interventions. And that is one of the aims. So we're taking very, very seriously what you said, the issue of costs. If it's too costly, it's not going to serve anyone whatsoever. And we can develop fantastic scientific advances that make no difference in population health, because they are unaffordable. That's not what we're aiming at. So how do we make it? And that's, again, why we require the brains of all of these very smart people that are part of the informal, as well as not just the scientific community. I think that highlighting your point too, how do we learn the scientific community from the other sides and perspectives? And one of the items is through forums like this one. We communicate our unofficial recommendations so that we can get the feedback from education specialists, from policymakers, from NGOs that are there on the reality. So that is the purpose. And we just started yesterday on creating these metrics. We want to move also rapidly and swiftly. So we're concerned about the issue of care, and we're concerned, of course, about the issue of efficacy. If the treatments are not efficacious, then we shouldn't even be thinking about it, and we should make it obvious such that the countries don't spend the very few resources they have in treatments that are ineffective. So that is where part of the big challenges that we have as us, we're just going to be providing recommendations to try to address it. You all are going to have to take them and then decide how to move it forward.
A very technical, logistic thing about, has been requested by Sudan, about the way we have recruited the people, the component of this informal scientific network. No? It is on the web or this. It was very easy because we have sent 3 years ago a note verbal to member states, to all member states, asking them to appoint their own representative. And we received a certain number of representative nomination, appointment, and we started to move with them. But we will do in the next few weeks, not months, a certain, such as a new round of this request to member states, in a way to enlarge and to have on board more and more people of countries that probably were not so they were a little distracted 3 years ago when we requested to appoint their representative here. So in reality, this network is informal, it is really informal, but with member states who have appointed their own scientists. It means that it is partially formal, because there is in any case a decision of the government to send someone and not someone else.
And to respond to the question raised about multiple conditions which are associated with this drug use, with substance use in healthcare settings, indeed, we know that comorbid conditions are rather a norm than an exception in the field of substance use disorders. That is why to developing specialized services for drug use disorders, it's absolutely necessary in every country with a significant burden. But it's not an only solution, because to increase the coverage of treatment interventions, of prevention interventions for substance use disorders, you need to address the whole healthcare system in general. So to engage other professionals who work in higher prevalence settings, to be able to identify and intervene in disorders at different stages of their development. And this is a big task. About the protocols, I want to say that to develop recommendations which can be applicable in countries with different healthcare systems and different resources is extremely challenging task. With this task, WHO is struggling for tens of years to develop particular procedures for developing WHO guidelines on treatment of different conditions, which are very special set of rules how to do this process. And currently, we have significant gaps in when it comes to substance use disorders. We have guidelines for treatment of opioid dependence, which needs to be updated in view of new recent developments on opioid antagonists. We have guidelines for opioid overdose based with naloxone management. We have guidelines on substance use in pregnancy, but we don't have guidelines on stimulant use disorders. We don't have guidelines on psychosocial interventions, which are included in several guidelines, but not as specifically as guidelines on psychosocial interventions. And we don't have guidelines on NPS identification and management. And in one of the resolutions at this CND, it's suggested for WHO to develop these guidelines. And then, based on these recommendations, we can offer or we can develop the protocols, because now the protocols are not cost neutral. It always implies particular procedures, structures, costs. And to recommend this for the whole world, you need a very rigorous, thorough procedures to come up with these recommendations. And that's, of course, for us, the future of the future work. It's a lot to be done. One issue that is of particular relevance is funding of substance use services. And this is something not only specialized, but overall, the interventions for substance use disorders. This is the greatest challenge. Now it's shrinking in many countries, this kind of financial pool available for this area. And we, at the end of June this year, we organized a forum on alcohol, drugs, and addictive behaviors, when funding of these conditions would be one of the major cross-cutting issues. looking at innovative approaches to funding these services. And I think this is one of the biggest challenges that we face right now. And it's not only about treatment provision, which is largely under the jurisdictions of the ministers of health and other governmental structures and non-governmental organizations, but it's also about funding of research, funding of prevention, funding of communication campaigns in general, so including this issue of young people, which definitely we are behind the time. And this requires different approaches. Thank you.
There is a
This lady's first.
lady, and then at the end of the room.
Go ahead.
I'm Julie Yates. I'm a family doctor from England, and I'm welcoming everything that the scientific committee is doing. It's wonderful to hear these things being debated sensibly and informally. I welcomed last year this international standards draft. It was a draft 12 months ago when I came in. It's still a draft, and this is frustrating me as a medical doctor. I'm representing 1,400 doctors from 103 countries around the world who are working in this field, and those of us and many people in this room who work in this field, we have seen with our own eyes, and Gilberto has seen how somebody can come in covered with abscesses, and you get them into treatment, cheap, safe, effective treatment, and the abscesses start to heal within 2 or 3 weeks. Now, I know that's a simple story, there's a lot more to it, and it takes a lot longer, but these evidences are in. And in some countries which are not even the most impoverished countries, we have levels of HIV which are increasing and rising. This affects the WHO, it affects all of us in communities around the world that this is happening. So I'm very keen that you get the message out fast and strong so that we can all around the world benefit from your good work.
Thank you. Thank you. We are now at the end of the room.
Yes, thank you, Dr. Gerra. My name is Vladimir. I come from RAN, which is a Recovered Users Network. And I have a question for Mrs. Wolkow. Ms. Wolkow. You were mentioning that disorder, which is very nice from our side, but you were also speaking about being a chronic and relapsing, and never mentioned the word recovery. So my question to you is it possible that scientific network didn't come across evidence all around the world that there are actually people who recovered from this disorder? And with this asking, we would like to be recognized and that this voice of hope and victory would be spread not only as the testimony of our month, but also as a policy message to all individuals with drug use disorder. So question and statement.
And I want to welcome and thank you for actually having brought that up, and I would suggest that indeed we should have stated not just that it's a chronic, complex, relapsing, multifactorial health disorder that can be prevented and treated, but also very explicitly state for which one can recover. Make it explicit, because that terms to be minimized in many of the documents. So I apologize. It's an omission. We're not perfect.
Thank you very much.
If I can respond also about this very important question. I came after a year, I found it is still a draft. We have engaged, particularly the WHO has been engaged in this process of field testing that is essential for them to give the official approval to a document. But when I came 10 years ago to work in this field of the international organization, I learned at a different pace in mobilizing the things. When you are paid in a treatment center to make an induction in buprenorphine to someone, you need some hours to do the induction, and that's it. And you can go home and say, I have done an induction in buprenorphine. Or you work at the village level. To work on the global village level, the things are so slow, and we need really to find the resources and to add. Fortunately, we have some initial resources for this field testing operation. I hope that next year, when you come to the Commission, you will find a luxury version of the of the international standard with a different paper, not only photocopy, and with the final approval of WHO, because we will have concluded the field testing. Shamaa.
Thank you. Just briefly, the discussion is becoming quite interesting. I have to admit. I just want to comment first on what Dr. Toufiq mentioned regarding the triangle, whether it's a triangle, rectangle, whatever, geometrical shape you want. But the point is actually the following, and that is the perception of the problem. And that is where the policymaker, the government official, as our distinguished colleague from Ghana mentioned, needs to be aware of the severity of a problem, what are the alternatives to solve a certain problem, protocols again, what can be implemented, and what can be implemented not connected to the particular interest of an individual, but actually for the public good. We were talking about the very correct word of humbleness. We need to be humble. What we propose in our discourse, because at the end of the day, all of us want to come out with a collective good. So that is definitely very important. Now, on the issue of treatment, what you refer to as my statement that there is no treatment. Well, the exchange that just took place now between the gentleman in the back and Dr. Nora regarding rehabilitation, well, that's part. There is a question. There is a question mark. I mean, you just need to refer back to the World Drug Report 2015. When you have a subtitle, why drug treatment is often perceived to be ineffective. So it's a matter of perception. That is perception related to how do you measure it, whether you measure it during the actual inpatient period, or you measure it and assess it once the patient is out of treatment, or the relapse of it, the relapse into the status again. So that is a question that is out there. But add to that, what compounds or even makes this issue quite tricky is what I mentioned to the sort of, if I can use that phrase, fake treatment. You know, there are such centers, maybe not in your town, but believe me, in other towns there is such a thing as centers that are open with the title of treating addiction. Now, how much of treatment of addiction they provide, well, your guess is as good as mine. But is there any record of people who come out of these centers? Have they been treated or not? Those who are who have been working with government or no such thing exists. And that is part of what puts this question mark on treatment. We can only help take out this question mark by the actual practical work that we need to do from now on, especially on the protocols, relating to the standards as well. Hopefully by next year you will take the word draft out, you will strike through the draft. But it's not only also about the standards, it's just one step. I mean, the standards and by themselves, fine, good, excellent. How can I apply them? How can I implement them? That's the whole point. So that's my point. I'm not saying that there is no treatment. I'm saying we need to be aware of the various factors out there in societies. That's why I was attracted very much by the phrase you used, that sometimes policymakers, government officials, whoever, is not necessarily 100% knowledgeable about everything that's taking place. You need to discuss, you need to talk with people, you need to perceive what are the factors that are in interplay in whatever given situation. Thank you.
Thank you, Excellency. Yeah, I don't want to dwell on it because this is not the topic of today. We're talking about the informal scientific network work, but believe me, I'm writing something about it because I work in developing countries and I know exactly what's the problem in terms of making things go bottom up, in terms of translating knowledge into policy making, and also making data collection at the service of policymakers. It's very tricky, very difficult, and believe me, it's. I'm not going to do it. Gentlemen.
Yeah. Ooh, that was pretty close. Thank you. My name is Alex Hoop. I'm a PhD student in sociology from Finland, and also part of the Finnish Association for Humane Drug Policy. I've been doing sort of ethnographic research among young adults in Amsterdam about drug use, and that's the sort of the perspective that I want to comment on that should be also thought about the user perspective. Why do they use drugs? What kind of harm reduction practices they're already using at the moment? Because a lot of the policies are sort of these top-down policies that are not necessarily looking into the perspective of the drug user, and they already have all kinds of implementations. We had a special edition last year in Contemporary Drug Problems, where we had all kinds of case studies showing how young people are already engaging in harm reduction practices that they share together, that they sort of develop themselves. So this sort of, drug policies have been sort of this sort of just say no and trying to be a top-down policy making, but it should be also looking at the perspective of the user from the sort of harm reduction from below practices as well. So that's just my comment to this discussion.
If I may respond to this question, this is a very important issue. I just want to flag that in the process of developing WHO guidelines, it's a required component. It's absolutely necessary to have the views and values from the target population. And also, of course, in the process of testing of international standards, this component is envisaged. So that's why but in principle, I think your question points out to a more general principle, that the voices of those for whom the work is being done, right, to protect their health, improve their well-being, should be always taken into consideration. Thank you very much for this point.
If I can add a thing, I want to use the motto, nothing about us without us, no? That is used by the organization of the users. And this is absolutely essential, because without sharing the decision, the medical decision, without the therapeutic alliance, you don't go anywhere. So this has to be done, has to be used also for designing the policy. Thank you.
And it just strikes me that this is something that we also need to add to our document, because of all of the voices that we were speaking, we actually do not explicitly address that of the voice of those suffering from the disease.